dream of perhaps being invited. So I thank you and Chris for the opportunity. We're going to talk about Bennett's lesions a bit here. My disclosures. So for those of you that don't know, George Bennet was actually an orthopedic surgeon at Johns Hopkins, and he first described this lesion back in the 1940s, and they were chiefly in throwers. And what this was more of an exostosis or an ossification off the posterior inferior glenoid, probably from traction type of throwing, close to the triceps insertion. And as was pointed out by Brandon Erickson, we know that deceleration is a pretty violent phase of throwing, slowing the arm down. We know the posterior inferior glenohumeral ligament along with the posterior cuff are going to be the, chiefly responsible for slowing that arm down. And it makes sense with over time and hundreds and thousands and millions of repetitions that you can start to get some ossification on that posterior glenoid rim. George Paletta will be talking to us later, and his work showed us that this isn't an abnormal or uncommon lesion. Almost a quarter of the throwers that he looked at that were asymptomatic with the Cardinals had this lesion. So it's not necessarily a bad thing, but something to be aware of. I was interested in this in my training, and when I started doing a deeper dive into the literature, I noticed that a couple things. Most of the literature was from Japan, and that the description of the Bennett's lesion was all over the place. Posterior inferior, posterior, fragmented pieces, attached pieces. Steve Burkhart described a pitcher's mound, which was an exostosis underneath the superior labrum, posterior superior. And that got me thinking, we're kind of putting this all under this Bennett's lesion umbrella, but we should probably have some type of classification. And we